There's the light on.
You're good.
Okay. Hello, everyone. So my name is Nicole Baba, B-A-B-A. Yes, I know it means grandma in Ukrainian, but it is not Ukrainian. I come from, my husband is half Lebanese, so it's from that part of the world. So I am one of the nurses that work in Saskatoon. Many of you, I look around and see a lot of familiar faces. I have more gray than last time you saw me too. I just color my hair.
I lose mine.
Yeah. So, you know, I appreciate you having me out, and I thank you for inviting me. So today I'm going to talk to you a little bit about a few things. So Murray gave me the survey of what everyone wants to learn for those that participated, and there were a lot of different things. One of the major things that people seemed interested in is aftercare, right? After you've gone through prostate cancer, what do you do about the side effects that occur? I have a bit of knowledge about it, but not all of the knowledge, so I'll share with you what I know. Before we talk about that, I'm going to talk to you a little bit about us as navigators. Where did this program come from? Where do we see it coming? What's changing in prostate cancer management and diagnosis? So a few different tidbits. And if you have questions, just raise your hand while I'm talking. I'm always open to stopping. I'm not like a rigid person that has to stay on. So let's go. Okay, so almost everyone that is in the male gender has come to be together today because of the PSA or that digital rectal exam. That's one thing everyone has in common. One of those things brought most, if not all of the men here together many years ago from very recently. Now, we all know that PSA just tells us that there's something going on in your body, especially in the prostate, but it doesn't tell us what's going on. PSA is often thought of as a prostate cancer screening tool. It is not a prostate cancer screening tool. It's just a marker for activity in your prostate. So the three things that can cause this to go up is your enlargement of a prostate. Every man's prostate starts growing at puberty, grows your whole lifetime. The rate at which your prostate's growing is predetermined from your genetics, kind of like your height or shoe size. Anyone that's talked to me recent knows I always say that. So some people, it's the enlargement that's causing elevated PSA. Others, it's inflammation, things like a urinary tract infection or prostatitis. But lots of men have chronic or acute, meaning long-term or short-term, just occurring inflammation that causes the elevated PSA. But for most of you, we know that it was the prostate cancer, but it's possibly even the other two that's also contributed to that years ago. Go ahead. So what sent you to the doctor was probably, you know, checking blood work, checking digital rectal exams, but then they realized there's something going on. So what in Saskatoon happens is that our family doctors or nurse practitioners, they get to choose what they do next. So family doctors and nurse practitioners, when they see a concern, they can choose to send you to the urologist. We've been doing that for decades, sending you to the urologist. But about 15 years ago, Dr. Visvanathan, who is still a urologist, and Corey Miller, who is now the head of St. Paul's Hospital, came together and said, hey, let's think about this new nurse navigator role. And then the Ministry of Health also came into the bucket, and we started to look at what do men choose to do when they have prostate cancer. And we learned very quickly, I'm talking more than 15 years ago, that the cutoff was Davidson. If you lived to the north of Davidson, you were more likely to have brachytherapy, the seeds or pellets. If you lived to the south, you were much more likely to have your prostate removed. Are we really that different after Davidson? So we realized, and this is widely known across the United States and Canada, that whoever gives you your initial information about your prostate cancer diagnosis and about the options is often the person that you trust, and you go with their treatment, the treatment that they are doing. Okay? And so if the doctor says, I think you should have X treatment, you're like, you are a good doctor, you've treated me good, you found my prostate cancer, I owe you, I'm going to have your treatment. And we know that that happens, even though we all think, no, it couldn't happen. We all have biases, even I have biases that I try not to put onto my patients. So They said, okay, who can deliver the information about the prostate cancer treatment options that's not biased? So that's where the nurse navigators came in. I always explain us like a car purchase. So if you're going to buy a new car and you go to the Chevy dealership, what do they tell you to buy? A Chevy. Maybe. But most would say a Chevy. If you go to the Ford dealership, they'll say a Ford. If you go to the Nissan dealership, they'll say a Nissan. And so our doctors are very similar. It's not that they think that they are necessarily the only person out there, but they all have a feeling that what they're doing is the best and most important. And I think that that's fairly common. So us nurses, we refer to ourselves as the used car dealership. We have all makes and models. Really doesn't matter what you do, as long as you do something that is best for you. So the pathway was developed about 15 years ago. We've been functioning for probably about, on our own, for about 12 years. And so instead of going to the urologist, which has been a bottleneck for probably 50 years, they said, how can we support family doctors and nurse practitioners to get people through the system more quickly? So that's what the pathway was developed by staff in Regina, staff in Saskatoon, the Ministry of Health, patient advisors, and that's where it came to be. It is a similar pathway in Regina, but Regina's Regina. They're a little different. Not necessarily bad, just different. I grew up in Regina, so I could say that. Now, so if your family doctor chooses to go to the urologist versus the pathway, the urologist, the problem is that we only have 7 adult urologists for probably 200,000 people. And so what happens is it's a long wait to see you, because every time a referral comes into the urologist, it goes to one of those 7, and they determine, based on what your family doctor or nurse practitioner sent, how quickly you get seen. You can get seen within 2 weeks, within 6 weeks, within 3 months, within 6 months, within 1 year, within 2 years. And so depending on your levels and depending on how many other people are coming in, they determine that. So we know that the wait to get seen was longer than we'd like it to be. So the other thing that would happen is that they would get their results in, but you are one of 200 people that they're taking care of. So they might not get to your results for a week or 10 days. And then they'd say, you have prostate cancer. We'll see you in about 3 or 4 weeks. And then you stew about it, right? And so that's where the nurse navigators came in. So you can come to the pathway, your family doctor can refer you, or you can go to the urologist. The urologists are so supportive of this program that they will usually send a letter to your doctor that says, consider the pathway. Please send them to there. Now, the pathway doesn't see everyone. There's really strict rules and guidelines. That's what the nurses do. We vet who should continue through the pathway and who should go to the urologist. So if you continue through the pathway, then we call you and set up the discussion about the biopsy. We book the biopsy if you decide to proceed, and then we call you with the results. And if it's positive, depending if you're low or intermediate risk, then we chat with you. If you're high risk, things change a little bit, then you go on to the urologist. We know that to see from referral to the urologist when this was developed to when you're diagnosed and have a discussion was 105 days. And with the pathway, it's 35. So that's where the pathway was developed. Now, we see patients that are just from the family doctors and nurse practitioners, but the urologists are very intelligent. So they send the patient back to us. Once they see them, they say, okay, here's your biopsy, let's have the biopsy. Okay, Nicole, can you call Mr. So-and-so with the results? Can you talk to Mr. So-and-so? Can you see Mr. So-and-so? So we work with both the urologists and the family doctors. So that's what the pathway is. Now, the pathway is starting to change again, which is good. Change is painful, but lack of change is worse in my opinion. Hit it. So the prostate biopsy, for the last 30 years, and probably the majority of you have had your prostate done through your rectum. Raise a hands. Who's had it done through the rectum?
Oh, yeah.
Okay. Now, it has been a good approach. It served us well. But that big downside is the infection. We know that 5% of men are going to get an infection. And that's nothing we can do about it. I track the stats. From what I know, it's between 4 to 7%. So maybe it's higher, but we don't know about it. But if we look historically from research around the world, it's about the same everywhere. Now, that's the first problem we have. The second problem is that the front of your prostate that is in the front of your body that the doctor doesn't feel, that's called the anterior aspect, the biopsy through the rectum is hard to reach or get that area, okay? That's the second problem. And the third problem is that, well, this is kind of a combination of problems, is that we find low-risk prostate cancer when we do biopsies that is stressful and pain and causing pain and potentially harm to people. So we really don't want to find low risk, right? And we want to be able to do the biopsies on the right people. So Saskatoon is changing the approach to prostate biopsies. About 3 or 4 months ago, Dr. Jeff Bird, who will be coming to talk to you, he took the initiative, went to Toronto, learned how to do prostate biopsies through your perineum. Your perineum is that patch of skin between your scrotum and your bum. And so the difference is you lay on your back with your legs up in stirrups, they tape the scrotum out of the way, they clean that area, they freeze the area, then they put in 2 needles. Those needles have a cathlon over it, just like the ones you put in your hand when you get an IV. They slide that cathlon in, one at about, I would say, 2 o'clock and about 9 o'clock, and they leave behind that cathlon. That's the entrance to get into your body the 12 times, because they still take usually 12 samples, okay? So the best thing about this approach is 0.3% of infection. So huge improvement. So that's the first thing that's beneficial. The second thing that's beneficial is they can reach the front of the prostate. So we can get those anterior cancers. Anterior prostate cancers aren't common, but they do occur. So it's those men that come, they have an elevated PSA, they do a biopsy, they find nothing. The PSA keeps going up and up and up. So they're those men. Yeah, exactly. Now, the third thing that's really important about it that we're going to talk about right away is MRIs. When you do a prostate biopsy through the perineum, you can do an MRI fusion prostate biopsy. So if you have an MRI, you can overlay the ultrasound perfectly and take a sample perfectly from that area. We've been using MRIs for several years now, but when we did them through the rectum, a biopsy, and we had an MRI, we'd be like, okay, that area is around at the top on the left, so we're going to take the needle about there, right? We called it cognitive fusion. I always like that, because cognitive fusion is, they're using their brains, they're doing the best they can. But now, it's really exciting for us that we can do MRI fusions. I learned about this in Chicago at a conference I went to about 4 years ago. So we're behind compared to the US, but we're hopefully starting to get there. Are we doing all our biopsies this way yet? No, we're not. We are doing 9 of them at St. Paul's Hospital that way. We call that transperineal. Trans just means coming from the bottom of the perineum up. And then we still do 4 at the University Hospital transrectal, bottom up into the rectum. Will that eventually switch? Yes. Eventually those ones from RUH will be going over to St. Paul's where they have more of the specialty. Any questions there?
Too late now.
It is too late now. But unfortunately, you're not alone. You're in good company. There's men coming down behind you all the time. There's downsides when you change and you make plans and you grow, is it comes with a bit of longer wait times. So we're working at trying to get those down, because to get a transperineal biopsy is about a 3-month wait right now. Exactly, that's too long. But to get a rectal one, 3 weeks. Why? Why isn't everyone rushing to the rectal one? We know why. So that's something we're working with.
We do.
Yeah.
Try and stay back with the lenses.
Oh, I'm sorry. I got really into it. Okay, carry on. Okay, so MRIs. The pathway was not designed to consider MRIs. That's the truth. When it was developed, like about 14 years ago, the MRIs to determine who we biopsy and how we biopsy wasn't really used. We've had discussions about in the past, should we do an MRI on everyone before we do a biopsy? Yes, no. Initially, when we discussed it, was that there wasn't enough proof yet that an MRI is effective, and there wasn't enough resource. But are we talking again about MRIs? Yes, because are they becoming really really important and more common? Yes. We never really talked about it because we didn't have the transperineal biopsies to fuse them, right? But now that we have that capability, I am finding when I talk to men, I tell them your option is a transrectal biopsy, a transperineal biopsy. The pros is that with a transrectal, you can get it right away. So if you're really stressed, you got a really high PSA, let's take the 5% risk. If you just have a marginally elevated PSA, if you're worried about an infection, let's go to the transperineal. And then the other option is going to the urologist who has a discussion with you, then books the MRI, then books the biopsy depending on the MRI results, which I'm going to talk to you about right away. So the downside you can probably figure out about that third option is bump, 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 longer wait, right? So we're just starting to reconvene the group that developed the pathway to say, do we need to make changes? Is it possible to have an MRI through the pathway to support family doctors or nurse practitioners? We don't know that. The answer isn't there yet. But I wanted to keep you guys aware of what's going on in our world because you are our world, okay? Okay, so MRIs for assessment is what I've been talking about. Doing them before a biopsy. MRI for staging. We don't do that many MRIs for staging. We usually do the CT and bone scan. Lots of you know that. If the CT and bone scan are inconclusive, then you go to an MRI because MRIs have longer waits, right? They're less accessible. And active surveillance, I don't know if anyone here is on active surveillance or had been in the past. MRIs are becoming extremely common, almost standard practice now. When you choose active surveillance, usually within 6 months to a year, you'll have an MRI to determine if active surveillance is safe. That brings us to the question, well, how would we know if active surveillance is safe or not by an MRI? What does an MRI tell us? How does it help us decide who we biopsy? Hit it. So, prostate imaging reporting and data system. They call it the PIRAD system. When they do an MRI, they can look at the prostate. It has to be an MRI that is strong enough to image the prostate. The prostate's a big, tough organ, so it has to be a strong enough imaging. The fee-for-service MRIs that are available in Saskatchewan are not strong enough. Patients always say, well, I'm going to go get my own. I'm like, okay, but don't do it here. Okay, go to Alberta where they have them. But when they see, we call it a lesion in your prostate. It's a tumor, essentially. A tumor can look very differently when it's a slow-growing, low-risk prostate cancer, okay, versus when it's a more active cancer. So when I say slow-growing, low-risk, that's the Gleason pattern 6 out of 10. That's the lowest number, okay? When I say a significant cancer, I'm talking about a Gleason 7 or above. Those are the cancers we need to find and treat because they could limit a man's life if we don't do it quickly enough and in a good time. So this PIRAD system is actually pretty simple. It goes from values of 1 to 5. So a PIRAD's value tells you the likelihood that there is significant cancer. So if it's a PIRAD's 1, it's a very low likelihood it's significant cancer. We're not concerned about that. If it's a 2, it's a low likelihood. If it's a 3, it's equivocal, intermediate. It may not be. But the PIRAD's 4, which is a high likelihood, or the 5, which is a very high likelihood of significant cancer. So if somebody's on active surveillance and we find a lesion like a 3 potentially, but mostly a 4 and 5, then we can target by doing an MRI fusion biopsy, see if it's actually safe for them to do active surveillance. That's a game changer. Now, same thing. Rather than heading right to a biopsy, can we do an MRI, see if there's any lesions? But then I say to a person, okay, you get an MRI, you have no lesions. Are you okay not to do a biopsy? So there's pros and cons with everything we do in life, right? Now, if we see a 3, do we do a biopsy? Do we not do a biopsy? If we see a 4 and 5, well, that's pretty easy decision. If you've never had a biopsy and you have an MRI, we've made the decision that you'll get your 12 samples, plus you'll get a targeted sampling from any lesions that are usually 4 or 5, sometimes 3. If you've had a biopsy and you're coming back for a second one, then you would just get targeted to the areas of concern. Any questions there? Go ahead.
Do the PIRAD 4 and 5, does that relate to the Gleason 4 or 5?
No, it does not. That's a great question. So people are like, so if I have a 4 or 5, like I have a Gleason 4 or 5? No. All it is telling us is there is a high likelihood you have a cancerous tumor in your prostate that is anywhere from a 7 to a 10, right? So even the 1s and 2s, you have cancer in your prostate, but it's not likely to be problematic, so we don't want to go looking for it, right? We watch them, then you get more MRIs, and as the PIRADs change, then you might need a biopsy, or then you might need to treat it. Yeah?
Yeah. Active surveillance is a new term to me. I don't know.
Okay, so active surveillance is the idea of delaying treatment until it's absolutely necessary. The idea is if we find slow-growing prostate cancer, we cannot treat it, we can watch it closely and see what it does. If I talk to somebody that's 51 on active surveillance, I say, this is delaying the treatment, delaying the side effects to give you quality of life. You will likely need to treat it. You're young, you've got a long time for that cancer to grow. When I talk to somebody that's 68, I say, we can watch it. Let's see what it does. It may never cause you troubles in your life. We don't know. So that's the idea. Active surveillance always has an intent to cure it still if or when it's necessary. Watchful waiting is often used as interchangeably with active surveillance when they're very different. Watchful waiting is the idea of doing nothing. I have prostate cancer. I don't want to treat it. Maybe I'm not healthy enough. I want to bury my head in the sand. That's it. I'll come and see you if I can't pee, if I've got bone pain, if I've got nausea, if I'm vomiting, if I have no appetite, if I'm losing weight. We don't do a whole lot of watchful waiting. Because if you're going to do watchful waiting, should we have done a biopsy? Good questions. Anyone else? I see my scholars back there. Yeah, Nicole's got it right so far. Okay, well, let's carry on then. Anyway, I'm really excited about MRIs because I think it'll improve the care that men have. I think transperineal biopsies are going to decrease the infection rates, which is huge. Do men like transperineal biopsies? They do not like the position. They find it very vulnerable. And so as a result, they are currently giving men Ativan, which is a medication to help you relax for it. But I always encourage men to talk to their partners if they've ever had any children, to give them tips, right? You know, how can I get through this? It is an embarrassing way to be positioned, particularly when everyone's down there poking away at you, right? Okay.
The black bag over the head.
So with the transperineum procedure, do they still map that area out through, like, with the MRI, with that imaging?
Sorry.
Some of the things that some of the things in the procedure that I learned about by visiting U.S. sites, for example, they do all of that, and then they've got a template where they map kind of that area.
That's exactly what we can do, exactly what the U.S. is doing now. Yeah. Do we have the depth of experience in our radiologists that we need to have? Not yet. We've only been doing it for a few months. Yeah. But yes, we can do that now. It's really, really exciting for us. Go ahead.
Yeah, the embarrassment thing and so on, for those of us who had brachytherapy, it's exactly the same.
Exactly the same positioning.
And it's not a big deal.
Yeah.
I don't know what it's like now, but when I went to Vancouver 12 years ago, they were all women working on me.
Yeah.
And they said things like, oops, during the procedure. When I was waking up in the office. But the other thing, I think that it's possible then, right, especially for brachytherapy, that the mapping can help target the placement of the seeds within the prostate, right?
I don't know, they won't give us a brachytherapy program, right? But it's all a similar approach. You still have, this is a good point, you still have the probe in your rectum. That's what you have to understand. That doesn't change. That discomfort remains because that's the only way we can see the prostate. It's just that the needle doesn't go through the bowel, it goes through the skin. That's why the risk of infection is so much lower. Yeah. But yeah, they're using similar technology when they're doing brachytherapy. Yeah. We don't have a low dose rate brachytherapy program here, so I don't know as much about it as I'd love to. Yeah. Okay. So, okay, we're talking about, what are we talking about here? This is the thing that most often kept coming up about that you guys were interested in learning some more about. So that's where we're going to head to that direction now. So it'll come as no surprise to any of you, I hope, that the prostate cancer treatments affect your bladder, first innocent bystander, your rectum, the bottom portion of your bowel, your urinary control muscles that control your flow, as well as those nerves that supply the erections. Does that come as a surprise to anyone? If so, come and visit me, later, okay? I have to say, when I started this job, my daughter is in her second year of university, and she was in kindergarten. So that's how I always know how long I've done this job. And so it's about 12, 13, 14, 15 years ago, I came to the support group before I saw any patients. I did. And I gave everyone a survey, because I was new to this job, and I was going to figure it all out. And they were angry. They were all angry because nobody listened to them. They were angry because nobody supported them. So to see this is amazing to me. And to know most of the faces is rewarding to me.
And if she had the opportunity, she'd know your penises too. She's the only one who's seen everybody.
I don't remember anyway. None of you are that remarkable. Only because they're all the same to me, truly. Okay. I'm really not that funny. Carry on. Okay, so sexual dysfunction. I always think of it, I usually interlay these as circles that all kind of impact and lay against each other. But in this one, there's these 4 pieces of the puzzle. There's a 5th piece that is here, but isn't usually as talked about. So I didn't put it there, but we still will talk about it. So when we think about your sexual function, the first piece that we need to have is the desire, the libido. If you aren't making the male hormone testosterone that you start making at puberty and make your whole lifetime, you don't make as much as you age. That's why your sex drive maybe isn't as high as you age for every man. But if you don't have sex drive, desire, it's hard for any of these pieces of the puzzle to work. They can still, in ways, but it's still more challenging for both yourself and your partner. So if you're on androgen deprivation therapy or hormone therapy, you don't have sex drive, it's hard to have the drive and want and desire when you don't have it, right? So sexual desire is the first key player in this program. The second piece of the puzzle is the erection. So we have the nerves that go from our brain, they head down our spinal cord, head across your prostate and into your penis. Those nerves essentially send the signal when you're sexually aroused in your brain to the penis. They say, penis, open those vessels, blood flows in, gets hard, and an erection is developed. Now, when you're young, that happens like that, and it happens right away again like that. As we age, the nerves, the blood supply, the health of the nerve deteriorates, and that's why most men as they age start to lose their erections. But when we talk about treating prostate cancer with surgery, those nerves are often cut or damaged, loss of erection results. When we think about radiation, those nerves are damaged, usually gradually, loss of erection develops. Now, ejaculation, with surgery, it's gone right away. There's no semen. With radiation, it'll often slowly, gradually go down. Some people all are different. Some will lose it quite quickly. Some will lose it never. They still have a little bit. The amount, consistency, color changes. You only need semen if you're trying to conceive. Most people I talk to are done with that, but not all. So I'm careful. Because I saw somebody today that was in their early 40s. And so you got to be careful with that. Now, if you're not having children, ejaculation, if it's gone, you don't need it. It doesn't make it more or less pleasurable, I am told, but maybe I'm wrong. Now, the ejaculate, though, I always say once it's gone, it's just a cleaner process, okay? More the women smile than the men, for some reason. Okay, so the last part is the orgasm. Always remembering orgasm is a brain function. You can orgasm with a hard penis. You can orgasm with a soft penis. Orgasm is achievable with either. But the piece of the puzzle we don't have here is that psychological impact from losing your erections, from losing your ejaculate, from feeling all of those emotions that come with those changes to your body and your relationship with your partner. And so some men cannot orgasm without an erection. Some men struggle to orgasm even with an erection afterwards. So everyone's different. There isn't one set puzzle that all of you need to stay with. So carrying on, please, Marie. So here are the nerves. I love this picture. It shows so well. So just so you all know, this is your rectum. This is your bladder. This is your prostate. And that's your penis up there. These are the nerves. So you've got your prostate, and then you've got the capsule. Think of it like the skin of a grape. And then you've got a little bit of tissue, and it's in that tissue that the nerves are plastered to each side of the prostate. Is that not a good picture to explain it, though? How intricate they are. Now, with the surgery, I tell every man, if you choose to have your prostate removed, which is equally as good as any other treatment, it's not superior, then you will have no erections when you first wake up. Okay? If there are no nerves spared, for most men, it will stay that way. There's a small group that it doesn't, that they get it back, but you're probably better off just buying I won't say a lottery ticket because that's pretty low odds, maybe a ticket in the home lottery. Okay? Now, nerve sparing, initial, I talk about that, nerve sparing procedure. So the idea is that can the doctor spare the nerve? When they spare the nerve, they have to leave behind the tissue where the nerve is laying, the capsule, and there's always a risk of leaving behind some prostate. And if there's cancer there, that's why your doctors have all talked to you if you chose to have surgery about how are we going to manage the nerves? Are we going to just cut them at both sides, leave them plastered and take it with? That's no nerve sparing. Or are we going to peel them off? Now, every man's like, yeah, let's spare them. Yeah, of course. I agree with you if I were you. But sparing a nerve does not guarantee return of function. Sparing 2 nerves gives you the best chance. We know that about half of men will develop some function. It is often partial function, but maybe those pills like Cialis and Viagra will get you there, and we're going to talk about that stuff. If you spare 1 nerve, you would think about 25% a chance of it coming back. It's probably between 5 and 25. It's really not well studied. I tell most men erections are not likely to be the same again after you have surgery, and that's something you have to accept when you make that choice. Now, what impacts if they're going to spare nerves or not? What's your function to start, right? If you couldn't play piano before and they spare the nerves, you're not going to be able to play piano after, right? So those men that are younger, that have good erections to start, they are usually more keen to try and spare nerves. Age, we just talked about that. Skill of the surgeon. We know that the better you are at it, the longer you've done it, the more you've done, in most cases gives you a better outcome. I'll leave it at that. I don't talk anything here about when you have surgery, your erection is one thing you lose, but you also lose penis size and length. Okay, people are like, why does that happen, Nicole? Why? I swear it was that long before, now it's this long. And I don't blame them because men will lose anywhere from 1/2 to 1.5 inches of penile length. That's a fair amount of penis. And why does it happen? There's discussion about because when they reconnect the bladder and the urine channel, we're pulling it together and pulling the penis in. Maybe a little bit, but we know it happens because of atrophy. Atrophy occurs very quickly, within weeks of your surgery. And that's when the penile tissue does start to shrink because there's just not that blood supply. And that isn't something that is correctable. When you have an erection, it won't be as noticeable, I tell men, but I can't correct that, fix that. Do I tell men that when I talk to them? I don't usually. Unless a person is very keen, is not feeling overwhelmed at all, I will tell them. But I usually leave that to the surgeon. Should I tell them? Come tell me if I should tell them. If you think I should tell them, tell me.
I would say yes. I would say yes.
Yes, you wouldn't feel overwhelmed? No. Am I incorrect in what I'm saying that this occurs, though?
I'm overwhelmed to begin with, so.
Yeah, so tell them.
Yeah,
okay.
I would say so.
Anyone say not tell them?
Surprise!
Yeah.
Why would you run away from the truth?
Yeah, that's fair. That's fair. So I've always left it to the surgeon that's giving the deeper. I always say, I give all the information, but not to the same depth that the surgeon does. So I've always left it to them. I don't know if they tell them all. They don't. Well, I'm going to learn from you today, and I'm going to take that with me.
It makes
Somebody told
sense,
me, but I don't know.
it makes sense that
Pardon?
that you know.
I said, somebody told me, I don't know who it was. Might
Yeah.
have been you.
You know, it makes sense that you know that the erectile tissue is going to scarify and shrink. And that's the reason why, because there's no oxygenated blood going in.
That's right. Yeah.
And so you end up with a button penis.
Some do.
Well, most.
Yeah.
And unless we stand in front of you and learn to inject,
Yeah.
you know, and then, you know. I'll let you-
And I can appreciate all of you saying that, and I'm going to take that and I'm going to apply it to my practice. I promise you. So, but the problem is that we as society have a inappropriate thought about what a penis should be, right? Society thinks everyone's penis is this big, then you're not good at it, or you're not desirable, when that's incorrect. There are many people that come to us and ask for penile lengthening, and they have a very normal sized penis. So there are some people, you're right, that aren't as endowed to start, and that makes it harder.
Size doesn't matter, right?
It doesn't. It truly doesn't. I promise to you.
That's a bunch of crap.
It doesn't. There is only 4 inches in the female vaginal canal that has sensation. Everything after that is waste. Okay? Anyway, we could talk about this forever. So let's carry on, please.
I don't know if I want to.
So erections after radiation. After radiation, the loss will still occur, but it's very slow. I always explain that it follows the same natural loss that has occurred as you've aged, but unfortunately it speeds it up. Okay? So why does it happen? There is damage to the neurological aspect of it, vascular damage, and muscular damage. So their blood supply to the nerve decreases, the blood supply to the oxygen to everything around there decreases. There is often can be some scarring. So multiple reasons. Carry on. Thank you. So I think that if there's something in my career that I'd love to learn more about, that I'd like to be better at, that I can see that I should improve on, it's the emotional aspect of managing erectile dysfunction. I recognize that. Would I like to learn? Yeah. Am I looking at ways that I can learn? Yes, I am. Have I taken a couple courses? Yes. But do I need more? Yes. Do we in Saskatchewan, probably in the world, need more emotional support for people that are in your situations? Absolutely. You're preaching to the converted. So I wanted to just touch on patients' perspectives, and I think maybe this will ring true to you. Maybe I missed some of it. So patients' perspectives when they lose their erections from treatment, particularly with prostate cancer, leads to feeling embarrassed. I heard that once already. It leads to feeling frustrated and not masculine, right? That you're not virile anymore if you don't have an erection. You're not a strong, potent man. Leads to denial, alienation, and avoidance. Then you don't want to deal with it because it makes you feel bad. We're all that way. That's the way we're designed so that we can function and survive. And then partners say, it doesn't matter. And I heard somebody say, but it does matter, Nicole. Because we stop believing that it doesn't matter when our partner tells us it doesn't matter after time. And then that leads to avoidance, which starts to fracture a relationship. This is the negative aspect. There's lots of people that never lead to a fractured relationship, but there are certainly some that do. Now, from the partner's perspective, they feel, well, we know that these are all women. So we have to think women have a bit of a different personality than men. So they feel frustrated, they feel sorry or empathy for your partner, and then you feel sadness. And undoubtedly, if this is my husband, I want to fix the problem. How can I fix it, right? And then they don't like that. He doesn't like that now. Imagine if he didn't have an erection, he wouldn't like that either. But and then a lot of women, by the time you start to reach these ages, start to have their own sexual dysfunction as well. Am I hitting it on the mark? Okay, I need to learn more. I appreciate that. So things that you can do. This I took off of a couple of things that I've been reading myself to try and improve my own knowledge. So understanding that erectile dysfunction is a medical problem. It is not something you did. It is not something that is because that your partner doesn't find you attractive. It is a medical problem. Talking openly with your partner, right? Often people will say, I don't have an erection anymore. So when my partner wants to hug or kiss me, I used to be willing to do that because it usually led to some more fun. But now they're worried that if they kiss them, hug them, then that will lead to your partner wanting to be sexually active, and then you think that you failed because you won't have an erection, so they turn away from that and don't talk about it. So talking about it is the key. Accompanying your partner to medical partner appointments. Whenever I teach people the injections that we're going to talk about, I'm so happy when I have their partner there. First, they don't feel like they're cheating on their partner. And second, that it's helpful to have that person support you. And then educating yourself about the ED and about the problems. And that's where I'm still at as well, educating our patients as well, and myself. Go ahead. So treatment, PDE5 inhibitors. That's the doctor's nice, and that's the oral pills, the medications like Cialis and Viagra we'll talk about. The vacuum device we're going to talk about, the penile injections, and the penile prosthesis. Carry on. So oral medications are called PDE5 inhibitors. I call them that because phosphodiesterase 5 inhibitors is too much for me. So those are the usual. Cialis, Viagra, Levitra are the ones that are available in Canada. And then Sendra, I guess, is available in the US, not in Canada, though. I've never seen that one. Go back.
Oh, I don't know how.
Just stay there. That's okay. Sit down. So we'll still talk about the pills. We'll just avoid the slide. So Cialis, Viagra, and Levitra. Levitra is rarely used. I rarely see that. I'll be honest, we only have samples of Cialis and Viagra. That's the only thing that we have. Now, they both have very, very similar effect, but the difference is that Viagra usually lasts about 4 to 6 hours. It'll stay in your bloodstream for 24 hours. Cialis can last for up to 36 hours. Knowing that the PDE5 inhibitors that we just talked about, they will only enhance an erection, right? And you have to have the thought process. You have to be aroused and want to be sexually active for it to enhance your erection. So after surgery, when you have zero erection, how many people have heard me say that? Zero enhanced is still zero. So that's why the pills don't work after the surgery. If they spare any nerves, or you're that small group even that didn't spare nerves that get some return function, then we switch to the pills, okay? Side effects, it varies. Some people have no side effects. Some people have headache, blue vision, back pain, all of it. So everyone's different. And just because you tried one pill and had side effects doesn't mean the next pill that works the same is necessarily going to give you the same side effects. That's why they usually try back and forth, okay? Okay, now the vacuum therapy system. I was going to bring my 2 vacuums and I forgot them. I'm sorry, honestly. But if you want to see them, come by anytime.
It'll be at the symposium too.
Yeah, that's right.
There's going to be there.
Yeah, which is great. So the vacuum therapy, where do you buy it? Who do you buy it from? How much is it? Who specializes in them? Who can help me with them? Will somebody teach me? So all of these questions have always been in the air. But I'm happy to report that Osbon Canada is the company that we usually, their devices are the ones that the urologists usually recommend. They have now been bought out by somebody new. Very good job on their website and much better job at supporting patients. So I'm happy to report that. So the Erecaid is the kind of vacuum device that they recommend. The manual one, the way it works is that this guy comes off, this goes on here, and then the little cap comes off, and it becomes like a cone. Then you lubricate all of that. You have to push it together there. And then these little rings sit on here, and you push it down by snapping that over it, and it sits on the edge of this right here. And then you put it onto the penis, making it suction to the body, and you pump it up with this little valve here. The release is on the back, and you draw blood in, and then you put the ring on, okay? Now, you can't go from 0 to 100. You can't put it on, pump it up, put the ring on, and you're good to go. It's a slow process. You have to go trying it for a while, then you stop, then you add a little more pressure, then you stop, and you do that for days until you get to where you're comfortable. Then you slide the ring on, and then you have an erection. Now, there's goods and bads. The good is that it's a one-time cost. Oh, by the way, this is the manual one. Pretty easy. You hit the button, plump it in, and then the ring's there, and you slide it onto your body. The cost is anywhere from $500 to $600. So they're pretty steep. And then the only maintenance cost is you have to buy the lubricating jelly, and the rings do wear out over time. Okay? And you got to trim the hair around there, because try and pull a ring off of hair is not pretty. The upside, though, I said, is that there's no needles. It does give you a good erection, good enough for intercourse, one-time use, less maintenance of it. The downside is that the penis is cold, right? Because we're trapping blood rather than it flowing through. The other downside is that half of your penis is on the outside of your body, and half of it is on the inside. Okay, sometimes a quarter is on the outside and half is on the inside, whatever you want to say. But there's a large portion of penile tissue, erectile tissue, that is in your body. And when you have an erection when you're 20, that whole thing becomes hard. When we do the vacuum device, it's only hard at the body where the ring is forward. So the back, if this is my penis, this stuff is soft. So it's hingy. So it still works good, but you can't be too aggressive anymore. You got to guide things a little bit. Does that make sense? Yeah. Do men like the vacuum? Yeah, absolutely. There's lots of men that like it and find it's very useful. I think it's about 60 to 80% that like it and continue to use it. Okay? Yeah.
It works like for my age, I'm 74 years old. It works for me too.
There's certainly a chance it will work.
I have robotic surgery already.
Yeah. Yeah, this is the option if you don't want the injections that I'm going to talk about next. Some people don't like needles. It's not worth it to them, and that's okay.
Because since I had my robotic surgery, everything went down. And
Yeah.
For my surgery, my urologist told me that, Gilbert, no more SEX.
Well, no more penetration is what he should have said. Right?
That's what he said to me before
Yeah.
my surgery. I said, oh my God.
Yeah. Well, sex is not just penetration. Sex is intimacy.
And even like right now, I have never had a sex for the last 7 months now. Everything is falling apart every time I see something in the TV that kind of censored. I don't feel good anymore. It's dead. Down.
Yeah, you're not alone. People say that to me all the time. They say, I really want to. I really think about it. I want to. Why doesn't anything happen? And I feel for you guys, because how frustrating.
It's okay for me. For me, I'm 74 years old.
Yeah?
I'm happy now.
Well,
because I have-
it's okay for you if you're happy and if you're okay with it.
I'm happy.
Doesn't matter how old you are. It's only okay if you're okay with it.
Wait till she gets past the needles to the penile insert. Then that's her answer.
Okay, let's carry on then. Yes, you could definitely try that. Osbon Canada. That's who it is. OSBON. Go Osbon Canada. It'll pop out the internet. You go on it. It shows you the options. And then there's also videos and such. So it's a good website. They've done a better job, I think. Okay. So this is what the next option is. This is a tough one, because I hold it dear to my heart because it really helps a lot of men, but I know that not a lot of men will continue with it permanently. Okay? So I always feel a bit of mixed feelings. So these are the chambers in the penis that fill with blood when you have an erection. They're called the cavernosal tissue. So these are getting into the cavernosal, that's those two chambers, self-injections. So you have to put a needle into the chamber. There's a thin membrane here, it will move throughout, and inject medication that will send a signal to your penis to dilate vessels, blood flows in, and you get an erection. This works in probably 60 to 80% of men. okay? So we teach you how to do this. You can use it every other day, up to 3 times a week, but you've got to learn how to do it. You've got to titrate the dose to find your sweet spot, good enough erection for intercourse, not too good to last too long, right? Now, the area you're going to inject is, I always say think about sectioning in half, inject the half closest and around this area. You have to avoid blood vessels, you want to avoid the head, the top of the penis, the bottom of the penis. Any questions?
Want me to put that where?
Well, you can put it wherever you want, but if you want an erection, it'll be the penis.
All it gave me was a hangover the next day.
Yeah. So there are some men that Cialis Viagra doesn't work. There are some men that have tried the vacuum and they don't like it or it doesn't work. There are some men that have tried these. One of the downsides is that there are people that it causes penile pain and it's not effective for them. There are some group of men that it just doesn't work. So that comes to the next slide.
Come on there.
The penile implants. So a penile implant is not a joking matter in the sense that once you make the decision to have one, you cannot go back, because those chambers that were in the penis are hollowed out and they are replaced with, usually the one we use most often is the 3-piece. They're in place of these 2 saline rods. Those rods are full of water to keep the penis form. And when you want to be sexually active, the little pump here, you pump up this piece right here, you squish it, it's in the scrotum, usually between your 2. It hurts a bit at first, you got to get toughened up. It does hurt, I've done it. Now, that sends the water from the reservoir into these channels to make it hard. Once you're done, there's a little T piece here, and in the middle of the T, there's a little button that you push. You'll feel or hear a little swoosh, and then the water flows back out. These penile implants were not covered by our health for many, many years. And Dr. Domes and patients and nurses really wrote letters to the government, and Dr. Domes was the key player, and eventually we got coverage now again. We got coverage just before the pandemic happened, right? And then what happened with the pandemic, right? No surgeries. We can't do any surgeries. Everyone's got COVID. So now they are starting to do a fair amount. So Dr. Domes is one of the urologists that specializes in it, that does it. The second one is Dr. Chan, who recently came to us about 1.5 years, 2 years ago. So those are the 2 doctors. So Dr. Chan feels that any man that wants this, he wants to help. When he first came, he's like, okay, Nicole, how do we find all those men that couldn't have it for years? I'm like, I don't know. Yeah, so unless a person comes to us and says, hey, I think that's something I want, then we can't find the people that came before it was allowed, which is a bit disheartening. We don't put out a poster, penile implants now acceptable, the government wouldn't be happy. They are only covered for men that have had a traumatic pelvic incident. So people that had like bowel cancer and the nerves have been damaged, people that had bladder cancer, prostate cancer. Doesn't cover people still. You don't get the coverage for a penile implant if you get it from diabetes, from obesity, from high blood pressure, from any of those. So we have coverage for men that have had prostate cancer, but not for everyone. Now, is it perfect? No. There's a small risk of infection. I believe it's only about 1%, less than 1%. It's pieces, so pieces can break, right? And so, but is the satisfaction fairly high? It is. Most men that have had it, usually that I talk to, recommend it to others. But we have to remember, just because you have an implant doesn't mean your penis is going to look like it did before. So I have a story for you. So we have a model at work, and of course the company that makes it gave us the model, Boston Scientific. And I go to look at this model, and I take the lid off, and this man's penis is literally that long. I say, what is this model for? And they said, well, that's the model. You can pump it up in the scrotum. It works really well. I said, but Everyone that gets an implant is going to think their penis will look like this, though. That is a problem. It really is. So it's unfortunate. So I tell men to now that we have coverage, now that we have 2 doctors doing it, we're having a bit more availability, do it sooner than later if you want to do it, because as you get that atrophy, they can't put as big of a model in there because scar tissue develops, and scar tissue is harder to work with.
You should be telling patients, Nicole, that right off the hop, and I've talked to you about this before. Right when you say, okay, drop your drawers, I'm going to show you how to put this needle in, and I stood there with my pants at my ankles, my wife was sitting there, you were sitting there, and I injected, and then the 3 of us looked at my penis for about 20 minutes waiting for it to get erect. And you said, I think there's one too many people in this room, and I said, that's your opinion.
I remember that.
I remember. Anyways, okay. So what I'm saying is, I got that, and I'm thankful, really
Good.
thankful. But the problem with it is, that should happen at the same time a prostatectomy takes place, because you still have your penile length.
Right.
You know, the surgeon knows you're not going to get an erection, you're going to suffer from atrophy, you're going to end up with a button penis probably, which is where I was at the point when, I thought it was Peter Lau did it, but maybe it was Chan.
He's like getting closer to retirement. Dr. Chan's taking over most of it.
So when Chan did it, he didn't have a lot to work with for me. So it was a matter of making as good a thing as he could. And then the next morning when he unwrapped it, I looked at it and I said, what the hell am I going to do with this? Because I was expecting this.
It was Dr. Dome's, I remember it.
But it was 3 inches.
Yeah.
And the thing with that is that it's 3 inches erect, 3 inches flaccid.
Mm-hmm.
It doesn't get any bigger, it just gets hard.
That's right.
So I guess in the perfect world, I wish that they would do that surgery right when they take out the prostate. Then you've maintained your length, you can still, for me, it was more an emotional, psychological emasculation. That's the word.
Mm-hmm.
And I hated it. I
Yeah.
didn't want to be here anymore.
So I think what I hear him saying is every person should be given the opportunity to make the decision
Right.
if they want to have an implant at the same time they have surgery.
And the thing was, is that it didn't, it was crazy, Nicole, but it never hurt. Like the next morning when Mom came in and unwrapped the thing, I had no pain. I mean, there was never any pain.
You're individual.
I'm different?
You're not different necessarily, but you're individual. Some people have a lot of discomfort.
Sure. Yeah, exactly. I mean,
Yeah.
I was on painkillers, but so the thought of a doctor going in there and reaming out. I mean, yeah, there's this thing going. I either got to put a needle in or that. I did the needle. It hurt. It burned. It was terrible.
Yeah, there's some people it just don't do well with it.
Mix of drugs there, 3 mixes. They tried changing the mix. It just wouldn't. It was just terrible. That was the best thing that ever happened to me.
Yeah, so I encourage any men that you meet, that you're willing to talk to about, that it is available. It is a good alternative. It was, before we got the coverage though, it cost about $12,000.
16.
It was 16 even up to then.
$16,000, yeah.
Yeah, and now it's probably even higher.
And I got it just before COVID. Phew.
Yeah, because we had just got that, because you were on our list of
Yeah.
people we needed to call, so. Any other thoughts or questions on that one? Go ahead, Vince.
You know, actually, what he says makes a lot of sense.
It does.
It said, because there's lots of women out there that get mastectomies, and they have the opportunity
Yes.
to have a rebuild right on the table, so when they wake up, they're like brand new, you know?
I like the idea in theory. I don't know enough about the surgery to say it's possible. Does that make sense?
Yeah.
Yeah. But maybe we need to do, even if we don't say right there and then, we need to say, these are the options, and if you're not happy, and if you want this, we need to know right away, right?
That's why a while back when you said, should I say something about atrophy, or yes, and this plays into it.
Okay, perfect. And Dr. Chan's ready. He wants all of those patients. Bring them in, he says. Nicole, if you could just find them, just bring them all in.
He's gonna come in the new year and talk about that.
Oh, yeah, good. And he is the key player here. And we're fortunate to have him and Dr. Domes, so. He'll tell you, that's a question to ask him.
Okay,
Because he's the guy that could take it all the way.
yeah. I ended up having to apologize to him afterwards.
Yeah, I don't know if, I think Dr. Domes did yours. Because Dr. Chan wasn't here yet.
It was an Asian fella.
Must have been Lau then, because he was doing them back then.
It was Peter, yeah.
Yeah, yeah, you're fortunate.
Yeah.
Okay, carry on. So, urinary incontinence. Dr. Chan will be coming to talk to you about it too. I'm giving you the laydown of the first layer of knowledge, and then you're going to get more from them. Okay, so incontinence. I really love this picture. It really explains what happens. So you've got the two muscles. The A is the internal urinary sphincter, sits just at the top of the prostate. This is your prostate here, by the bladder. And then B is the external sphincter right here. That's your pelvic floor muscle. So when they do surgery, that internal muscle, most if not all of it, is injured and gone. So after surgery, this is the muscle that takes over most of the work. Okay? Carry on. And also the prostate also puts pressure on the tube to also help with control. Sometimes too much pressure, right? Yeah. Okay, so urinary continence after prostatectomy. I used to say, every man is going to leak after you have your surgery. Be prepared for it, man. Soldiers. But now things have changed a little bit because over a year ago, we got the robot. Do we know that the robot is going to help men gain control? No, we do not. But when I call men and talk to them, do I hear, oh, Nicole, I hardly had any leakage. I didn't even wear a pad for a week. I am hearing that. So now I say, most men will have incontinence. Some men, it will take weeks to get better. Some men, it'll take months. The majority of the control you're going to gain will be in the first 6 months. Gradual improvement till about a year to a year and a half. By about a year to year and a half, you are where you are. And if you have the incontinence, then we need to talk about some alternatives. And I think we're pretty good at saying to men, if you're not happy, I know the urologists say, if you're not happy within a year with your control, call us back, come back to us. So, carry on, please. With radiation, the urinary muscles are still there, but radiation causes tissue to get stiff, so it doesn't contract quite as well. So that's why you can develop incontinence. I always do the 5 to 15 year scenario. 5 years after prostatectomy, about 17 to 20% of men are leaking. Okay? With radiation, it's only 2 to 4%. If we look at 15 years, we have about 20% each of them, 17 to 20%. So the playing ground does equalize, but it takes 15 years. Does that make sense? Yeah? Okay. Carry on. That's why it says 15 years after any treatment, about the same amount of men are leaking. So, treating urinary incontinence. It's important to know that some men live with it. It's mild, they manage it, and it doesn't bother them. But there are men that it does bother, so we're going to talk about the penile clamps, the sling procedure, and the artificial urinary sphincter, and Dr. Chan is the specialist in all of them. Dr. Lau used to do the majority of those cases as well. He's still working, hopefully forever, but not likely. So it is moving into Dr. Chan. We're really fortunate to have Dr. Chan. Not only does he do these procedures, he also does urethral procedures. When men had scarring or narrowing of urethral procedures, which can occur with any treatment, but brachytherapy tends to be the one that gives us the most troubles. We used to have to send men to Dr. Rourke in Edmonton, and he would cut out a portion, fix it, take a piece of tissue from the lining, rebuild it. But now Dr. Chan does it here in Saskatoon. So we're really lucky to have him.
Nicole, you talked about percentages and the difference between the two types of therapy and so on. How does that relate to age-related issues that are similar? I mean, when you get to that 20% in both cases at 15 years, most of the guys at that age are, we're in our 70s. Maybe
You're starting to leak anyway.
And yeah, is there?
Some of it is from the radiation and some of it's from aging.
Yeah.
I don't think we know.
Yeah.
Yeah, that's a good point though. Yeah, it's not necessarily just the treatment. Yeah, okay. So penile clamps. most men are like, oh. I'm putting that where? That's almost as bad as the needle. They have a place though. They work for men if you're leaking and you want to go to the beach, right? If you don't want to have leakage, if there's a really special thing like a wedding, things like that. So the Weisner has a hard area, I'm going to use this spoon, right about here that goes under the penis. That's where you want to aim it at the urinary channel. This one you can get online for about $60. The dribble stop is a Canadian-made one. You can change those little plastic pieces to make it larger or smaller if you have a button or a bigger penis. That is made in BC, and it's about $100, $120 for 2 clamps. The Cunningham, I'll be honest, this is for the older guys that have had incontinence for years, because it's a really nice device, and they're not scared that it looks a bit barbaric. They're tough. And that's about $80 online. You can buy it here at the Euro Medical Supplies and I believe at Nordon for about $80 to $90. They've all gone up recently. I don't like the Pacey Cup. I've never seen anyone use it. So that's it. Any questions there? I'm sorry if you like the Pacey Cup.
A little uncomfortable on Cunningham.
It's a little uncomfortable?
Uncomfortable.
Yeah? Yeah. Well, and the other thing is that you have to make sure.
Other ones aren't so bad.
The others aren't so bad?
No.
Well, thank
Well,
you
they're
for
not so
sharing
wide.
that.
They're not so wide.
Yeah.
Yeah.
Yeah, the Cunningham's about that thick.
So
Yeah.
about two-
But I think it
two
lasts
inches
a long
across,
time.
Yeah.
But I think it lasts a long time.
You've got to walk like this.
Yeah. Thank you for sharing that. Have you tried the Pacey? Did you try the Pacey?
No, I have not.
Yeah.
It's way too.
Yeah. I think if it were me, I think I'd go with the Weisner.
Yeah.
I like that one.
It just,
I've tried them all on my finger.
It's just to control urine flow.
Yeah.
The whole bit.
Yeah, but the dribble stop looks nice. It's just not quite as firm, but I know this piece down here has broken off for patients, they've told me.
The plastic ones, the dribble stop is easier.
Is it really?
Yes.
Good to hear. Okay,
well on the beach in Mexico too.
Is there,
good.
is there enough pressure that it cuts off blood?
No, it just compresses the urethra. It doesn't cut off blood supply. You don't want that. You're wearing it too tight. That's the ring from the vacuum. That's why you can only have it on for 30 minutes. Okay, carry on.
Okay.
So the sling procedure. I am completely going off of what I know from taking care of patients and what I read on the internet. I'm going to be honest here. Okay, so Dr. Chan is the guy to talk to about this. So when you have mild leakage, that's the key. Minimal leakage. I think they say going through like less than 1 to 2 pads or something like that. That's when this procedure is going to be considered. Because if you go through like 3 or 4 pads, it's not going to be effective. So you have to have mild leakage. They put a tape or a mesh underneath here, and it slings through, and then it compresses the urethra. So essentially, the urine has to go uphill before it goes down. So this is good for stress incontinence and mild leakage only. Okay?
Is that surgically installed?
Yeah, it is. Yeah, there is just a few cuts down here, and there's often a cut down below. You have a catheter overnight, and then we take it out in the morning to make sure you can pee, because the possibility is that too much strength, too much tightness.
Too tight.
Yeah, exactly.
So then if you have this and you want to pee, is it a lot harder to pee?
No, it works very well.
Oh, really?
Mm-hmm.
I would have thought you'd have to.
You don't have to push too hard. If you're pushing too hard, Dr. Chan doesn't like that. That hurts your bladder. He gets very upset with that. Yeah. Ask him, say, so would I have to push too hard? He was, no pushing. So he tells all his patients. Okay. So the artificial urinary sphincter, this guy's been around for a long time. I've nursed for 25 years, and when I was a ward nurse, I remember taking care of people that had this, because in those days, they would stay in the hospital for probably 4 days. Now it's a day procedure. So I like to think of it, this little cuff goes around the urine channel. Think of it like a blood pressure cuff, okay? It's always inflated with water. When you need to pee, there's a control mechanism. This button here is convex, and so this is the activation. You don't touch that unless you needed to deactivate it. You push this button when you need to pee, because your bladder still feels a sensation. It moves the water from here through into the reservoir. And then you pee, and then you do nothing. within about 10 seconds, 15 seconds, I don't know exact time, the water just flushes back into the cuff. Okay, that's an artificial urinary sphincter. Like I said, well, this is terrible to read. I'm sorry, guys. 2 to 3 pads or more is for these people. Most people, they can get pretty dry, but not completely dry. Probably don't use this spoon to mix your coffee. Okay, carry on.
That weakens after years, after a number of
Yeah,
years.
and they can replace the parts, though.
Oh, is that right?
Yep, they can replace the parts, I know.
So you don't have as much leakage.
Yeah, they can replace the cuff if it's starting to get weak.
Oh, is that right?
Yeah, you'd want to be referred to Dr. Chan and see if he can do that. Other people are like, yeah.
That's
The-
another surgery, though.
That's right. So it depends how much it bothers you. The first thing I said is, does it bother you enough? Can you live with it, right? Yeah. Okay, that's it, guys. That took way longer than I anticipated. I'm sorry.
There was some dialogue.
Yeah, I appreciate that. That makes it more interesting. Keeps everyone awake at 8:15 at night. Yeah. Any thoughts or questions I welcome? Go ahead.
Yeah, I just, you know, you always talk about there's some people coming through, and I've often wondered, like, how many new people come through your system every year with prostate cancer?
So we do about 500 biopsies every year.
Okay.
And anecdotally, I'll guess about 200 to 225, sometimes 250. We have a fairly high pickup rate, like high positive rate, because the urologists don't biopsy everyone. And the pathway has strict guidelines.
Do you
Yeah.
have any idea about how many people choose the surgery as compared
We haven't looked at that since before the pandemic, but on every one of you that's been through the urologist, I have to fill out a form. And with that form I might call you because every form I have to complete about what you did. So I might call you and say, hi, I'm just following up what you did because I can't figure it out. And so we write it down. The last time we checked it before the pandemic, it was a third split. A third had surgery, a third had external beam, and a third had brachytherapy.
But that all depends on the Gleason.
Yep, that's all comers.
Yeah, exactly.
All comers. That's men that can't have surgery, are too old, that end up having radiation. Men that have Crohn's or colitis can't have radiation, has surgery. It's all comers that treat their prostate cancer. We aren't including the active surveillance. Yeah.
So those numbers aren't a fair representation.
Well, they're not a fair
really, of an
representation
average.
because not everyone goes to the urologist. There are some people that go right to radiation oncology.
Right.
Yeah.
The other thing with that sphincter is, one time I accidentally pushed on the black button. I was bursting.
Deactivated it.
Yeah, I was ready to go drive all night to get there.
Yeah. Yeah. The other thing is you have to have dexterity.
He told me how not-
Now he taught you?
Well, he just told me on the phone,
Oh, good.
Yeah.
Just push that button.
push her hard.
Yeah. You have to have the dexterity. That's the other key. You have to be able, for both the penile implant and the artificial urinary sphincter, you have to be able to manipulate those hard plastic pieces. Okay.
I was in exercise this morning, and a woman was in there, and she was talking to me about her tattoos. And she said to me, do you have any tattoos? And I said, yes, I've got 2. I've got a blue dot on my hip and a blue dot right above my penis. I said, for radiation.
That's a good
I'm not
one.
getting anymore, because that hurt.
I have one. I'm not taking off all my clothes. I have a B. I got that in December because I have 3 daughters, and the youngest one turned 18 last December. So they're Bs, and if you put all our arms together, it flies. Yeah. That's the only one I'm ever getting because it darn well hurt. Yeah.
And you could have got infection.
Yeah. Yeah. Possible. I know how to treat that. Okay. Well,
Come on, we got her.
well, you can access me anyway, right?
Oh, there's that.
Yeah, you can phone me anyway.
Anybody come?
Can anyone come?
Well, I had my prostatectomy 20 years ago,
Uh-huh.
and you weren't around then.